Hello, today we'll look at COPD and the treatment of it, and we will look at something called exacerbation. So there are another video that I made. This is called the stable patients, so the treatment of stable patients. But in this video, we're dealing with exacerbation. That means that the patient gets a lot of symptoms. So he's coming to my office or a doctor's office and complaining about difficulty breathing, for example, and it's very, very, very hard for him to breathe compared to normally. Okay, so a patient who has COPD normally have difficulty breathing, but when he have exacerbation, it's even worse. And then he will come and we will look at the treatment of this patient now. So he comes and I will check some things, physical examination it's called, and we will look at the patient, is he wheezing or not? Tachypnea, that means an increased amount of breathing, difficulty speaking, use of accessory muscles, asynchrony between chest and abdominal motion. So we will look at one by one. Wheezing, this is a wheezing sound, like a musical sound that is coming from the patient. Please look at videos on YouTube and you will hear what it means. Tachypnea means that it's more than 20 breathings per minute. Usually patient have around 16 per minute, and if you count it's like 20, 30, 40 per minute, then you know it's tachypnea. So this is an exacerbation of the symptoms. Difficulty speaking, so the patient tries to speak to you but he cannot really do it. It's difficult for him because he don't get any air. And use of accessory muscles, this is a muscle group that will be used now. This is called sternocleidomastoid muscle, is a Latin name. And we will use these accessory muscles because the normal diaphragm that is usually there to make you breathe is not really enough. So the patient gets not enough of oxygen in his body and he has to use this sternocleidomastoid muscle, which is an accessory muscle. And you will see that this is contracting in the neck region. And also in the ribs, there are some intercostal muscles that will activate during this exacerbation. These are accessory muscles. Asynchrony between chest and abdominal motion. What does this mean? As you inhale, you see that your stomach will go down, one can say, because the diaphragm goes down. Because when the diaphragm goes down, then your lungs have more space. But the asynchrony between this is when, for example, the diaphragm is going upwards instead and the chest wall is going outwards. So normally chest wall goes outwards and the diaphragm downwards, and in this exacerbation, this asynchrony between this means that they are not synced. They are not working as normally. Which test do we perform now? So we have a patient, we saw all these things that we said. We will now look at pulse oximetry. That's the first thing you will do as a doctor. You put this small device on the patient finger and then you can see how much % of oxygen there is in his blood. Then the next step is to check an arterial blood gas analysis. That means that you will puncture the artery and you will suck out some blood and look at it into a small point of care device, and in this point of care device we will get some values. And the indication of doing this is that the patient comes in with the symptoms that we talked about, this acute exacerbation. The pulse oximetry shows that it's less than 92% oxygen. And 30 minutes after we give some oxygen to this patient, because he needs oxygen quickly, 30 minutes after giving this oxygen, we will now check this arterial blood gas analysis once again. Why? Because we need to prevent any severe hypercapnia, it's called. Hypercapnia means that we have a lot of carbon dioxide in the blood. And we have it because it's hyperventilating, okay? And lower consciousness. So these 4 points that you see here are indications of using arterial blood gas analysis, which means puncture the artery. So acute exacerbation of COPD, as we said, pulse oximetry is less than 92%. 30 minutes after we give oxygen, we need to remake this arterial gas analysis again. And lower consciousness. So the patient, you see he's lower consciousness. These are all indications of doing arterial blood gas analysis. And the thing that we will see here is, as we said, hypercapnia, and we want to prevent this because if we give a lot of oxygen to these patients, we're giving it through the nose, and we increase it to 2 liters, 3 liters, 4 liters, 5 liters per minute, and then it becomes hypercapnic. So in the blood, when we take this blood gas analysis, we see that the carbon dioxide starts to increase. Then we need to reduce the oxygen level, okay? So hypercapnia just means a lot of carbon dioxide in the blood. And hypoxemia means that we have a low amount of oxygen in the blood, okay? And this can be seen with arterial blood gas analysis. So the thing that we'll do now, we have done pulse oximetry, we have done this arterial blood gas, we will do a lab test. And the lab test can be BNP, D-dimer, electrolyte, glucose, and complete blood count, okay? And it's important to emphasize here, this question says, is it possible to diagnose COPD with lab test? No, but why do we do it then? Lab is only used to exclude other causes of dyspnea, so other causes of difficulty breathing. That's the only reason why we do lab test here, because we cannot diagnose COPD with a lab test. It's not for the diagnosis, it's for to exclude other causes of difficulty breathing, because you should not think that COPD is the only disease that can cause difficulty breathing. There are a lot of more diseases that can cause them. The only thing here I want to highlight is that alpha-1 antitrypsin deficiency is the only important lab test used in COPD. That's the only thing, because alpha-1 antitrypsin deficiency, you are born with that. It's a genetic disease, can cause a higher amount of COPD in patients. More patients will be affected when you have alpha-1 antitrypsin deficiency. So COPD, please don't do lab for diagnosis, but do it to exclude diseases with BNP. Let's see, what does BNP do? And we assess heart failure. So heart failure patients can have difficulty breathing. Therefore, you do a BNP testing. D-dimer test, used for pulmonary embolism exclusion. So remember it, pulmonary embolism. This is a thrombus that is blocking your arteries, for example, in your lungs, okay? So please do a D-dimer test, because maybe that is causing the difficulty breathing. Electrolytes, you rule out any hypo, hyper, natremia, or hypo, hyperkalemia. These are low and high levels of sodium, low and high levels of potassium. Okay, this is very important in COPD. Rule out these things, because all these things can cause difficulty breathing. Why do we check a complete blood count in a patient with difficulty breathing? Only to rule out anemia. Anemia means that we have a low amount of red blood cells in the blood, which means that the patient gets difficulty breathing, because the oxygen is transported with these blood cells, and therefore it's important that you check and rule out any anemia. Okay, we did these three things. Now we go on with chest radiograph. Chest radiograph radiographically can be a good picture of COPD. It's very easy to picture, and it's important to picture not COPD itself, but we exclude pneumonia, so lung infection, we exclude pneumothorax, we exclude pulmonary edema, and we exclude pleural effusion. These are four things that you need to exclude with a chest X-ray, because these are also things that can cause difficulty breathing. So all the tests I'm doing here is to exclude other diseases. Okay? Because maybe we know the patient have COPD. We know we see it in the chart. It's known for 2 years or 3 years. That's okay. We know that COPD, it could be difficulty breathing due to COPD, but it could be due to other things also. And if you don't exclude, for example, a lung infection, pneumonia, then you cannot treat this patient, because if you see it on the chest X-ray that this patient has pneumonia, lung infection, then you need to give antibiotics and treat this patient totally different. So COPD treatment is not the same as a pneumonia treatment, okay? Pneumothorax, this means that you see 1/2 of the lung is not functioning anymore. It's totally collapsed. Pneumothorax, okay? It's pneumo, it's air in the lungs. Pulmonary edema, it's a lot of fluid, it's a lot of edema in the lungs, and that is causing that the patient have this difficulty breathing. And this can be seen in chest X-ray. and especially in patients who have heart failure. Heart failure patients will get a pulmonary edema and difficulty breathing. And remember that COPD patients usually have other diseases also. Many patients have more diseases. We call it multimorbid patient because he has heart failure, he has blood pressure is high, the COPD is there, he has diabetes and so on. Okay, so we rule out also pleural effusion. This is also fluid in the lung, but it's more between the lung tissue and the chest wall, one can say. So it's a pleural effusion, and we can drain that. You see this? We puncture it and we drain it out, and then the patient can breathe again. Maybe he has a cancer. It's a tumor. Many tumors are causing pleural effusion. We need to check it with chest X-ray to rule out all these things. When do we do sputum gram stain, culture, or PCR? These are all tests that we take from, one can say, the saliva or the mouth or the region from the sputum, one can say. You take a sputum culture and you check it in the laboratory and you check for any type of infections. So any type of bacteria and viruses and so on. And the most common cause of COPD exacerbation is, what do you think? What do you think is the most common cause of this exacerbation? So patient has COPD. What do you think is triggering most of these acute symptoms? Lung infection. And we said chest X-ray to rule it out and check the blood samples to rule out any infections and so on. So chest X-ray, here you see a picture, and this will then cause exacerbation, and therefore we need to treat it with antibiotics. How many percent of exacerbation do you think are caused by this lung infection? We said most common, but what do you think? How many percent of patients? Out of 10, how many patients? 8 patients out of 10 are causing exacerbations from a lung infection. So lung infection causing that. 80%. That's incredible. So it's very important to know now which are the rest 20%. The rest remaining 20% are total different things. Environmental pollution, this is general stuff. Pulmonary embolism, we said that already. D-dimer test. We took a lab and we checked the D-dimer test for any pulmonary embolism. Eosinophil inflammation, this is also seen in the lab test. We see that eosinophils are increased in the blood or unknown etiology. We have no clue. Okay, so these are the rest 20%. Environmental pollution, as we said, this is all around us. Pulmonary embolism, this can be caused if you're having a thrombosis in your legs and then you're, for example, making a very nice trip to somewhere which is taking you more than 12 hours or so, and you are sitting too much, and then the blood starts to get slower and slower and you get thrombosis. And then when you move, you go out from the airport, bam, you get thrombosis that is going to your lungs and you don't get any air. So you get difficulty breathing, pulmonary embolism. Eosinophil inflammation, these are a picture of eosinophil, and this can be checked in the lab, as we said. Unknown etiology, we have no clue. So remember this, 80% are due to lung infection, but the remaining 20% are due to these things, okay? In what ratio do you think that viruses and bacteria are causing lung infections that result now in COPD exacerbation? It's 50-50, okay, around 50-50. So it means viruses and bacteria are both important. Which are the most common viruses causing lung infection? Rhinoviruses, which is the most common one, influenza, parainfluenza, coronavirus, adenovirus. Rhinoviruses, nice picture of that. Influenza, also a very nice picture of that. So you see, these are just for you to remember how they look like. Parainfluenza look like this. Coronavirus look like this. Adenovirus look like this. Very nice pictures. Which are the most common bacteria causing lung infection that cause COPD exacerbation? We had the viruses, which are the bacteria. Haemophilus influenza, Moraxella catarrhalis, Streptococcus pneumonia, Pseudomonas aeruginosa, and Enterobacteriaceae. Haemophilus influenza, you see it here. Moraxella catarrhalis, Streptococcus pneumonia, Pseudomonas aeruginosa, and Enterobacteriaceae. Remember all these, viruses, bacteria. Co-infection means that bacteria and viruses are causing it at the same time. We said 50%, but they can also interact with each other and help each other, and then they cause infection at the same time. That's a co-infection. That's pretty sad, because now we need to somehow tackle both of these, okay? What can be a sign of bacterial infection? So what do you think? You look at the patient and you say, without any lab test, without anything, any tool, you say, this is a bacterial infection. What do you think? Purulent sputum. When you see that the patient is having a sputum spitting out and it's greenish, yellowish, greenish, then it's pretty sure that there are bacteria there. It can be a co-infection. It can, of course, be viruses also with a bacterial infection too, but a bacterial infection is there. And why is this important? Viruses cannot be treated with antibiotics. Bacteria can. These are called antibiotics. Bacteria against bacteria. Do we perform a sputum gram stain or culture for every patient that has COPD? Sputum gram stain just means that we take sputum test and then we check how it grows. It grows in the laboratory and then you see which bacteria grows and then you know that you have to attack that one. And the answer is no. You don't perform it for every patient. It would be too cumbersome and too costly, okay? So you only will be testing it for patients who have risk factors for Pseudomonas infection. We have antibiotics, which had not helped until now. It didn't help. And then you have a patient with acute respiratory failure. These three main patient groups have to be tested with sputum gram stain. So risk factor for Pseudomonas, we'll look at this. This is a type of infection here. And the risk factor will be previous isolation. For example, he was in the hospital for a couple of days ago or weeks ago. And then we have the previous isolation of Pseudomonas. He have a disease that is called bronchiectasis. He takes frequent antibiotics and he visits frequently the hospital, and he also takes a lot of systemic glucocorticoids, so medication that is steroids, and he have severe COPD. So either of these risk factors, then you do a sputum culture. Okay, please remember this. So previous isolation of Pseudomonas. It's a nice picture. You take the sputum, you look in the lab for Pseudomonas. Bronchiectasis means whitening of this bronchi. This is a disease. And frequent antibiotics, he takes it very, very regularly. Frequent hospital, he's laying in the hospital many times a year. Systemic glucocorticoids, why hand? Because steroids and muscle. So it's a frequent systemic glucocorticoids. This is a medication, has nothing to do with muscle, by the way, but this would just make a good picture so you remember it. And severe COPD, you see this obstruction because COPD means chronic obstructive pulmonary disease, so it's a chronically obstructive disease, and you can see that these airways are really, really obstructed here. Okay, and which patient should now be tested for sputum gram stain and culture? We said risk factor of Pseudomonas, and if antibiotics does not help, you see this bacteria, you gave antibiotics and he just jokes with it, okay? He just plays around with it. He's smarter than the antibiotic. In this patient, we need to take a sputum gram stain. Why? Because we need to attack this. We need to attack really this bacteria with a strong antibiotic against this specific bacteria. And how do we know that this is the bacteria? Because we took a sputum culture and we grow it in the laboratory and we see that, aha, this is the type, because there are many, many different types of bacteria. And we can not attack everything broadly all the time. If the antibiotics does not help, we need to attack it specifically. Acute respiratory failure. This is also a patient who needs a sputum culture. Okay, acute respiratory failure is very severe. The patient can die. Which test is used to detect bacteria? Sputum culture on gram stain, as we said, and this is how it looks like. We culture it on these agar plates, and then we will see on these red agar plates which are growing or not. The viruses are not detected with this gram stain. It's totally different. It's a PCR test or a point of care device can be used also. So PCR test is a total different molecular DNA testing thing. Okay, it's much more complex, much more costly, and so on. But it's important to do if we suspect a very, very severe virus. Point of care device is also important because this is a device that we can use in the office. Okay, we just put some blood sample there and then we get an answer very quickly. Disadvantage of using a point of care device compared to a PCR is that the point of care device has a sensitivity of only 5%. It's very low to find the disease. So these are not so good. PCR test is the best one. Okay, so sensitivity is very low for point-of-care device. The viruses that can be detected by PCR are many. Influenza, adenovirus, parainfluenza virus, respiratory syncytial virus, human metapneumovirus, very interesting names, coronavirus, and rhinoviruses. Okay, and our rhinovirus is the most common one, as we said, so we need to find out if it's that one. Influenza, this is a picture of that. And the influenza virus should be tested in all patients with COPD all patients with COPD exacerbations. Okay, so please remember that. Adenovirus looks like this. Parainfluenza looks like this. Just for you to remember the picture of how beautiful actually these bad viruses are, or bad bacteria. Actually, they are not so bad in themselves. They have a purpose in life also. Okay. But in this case, this is causing a disease. Here they look very nicely. Three-dimensional pictures. Coronavirus and rhinovirus, as we said. Okay? Which diagnostic tool can we detect the damage caused by COPD? So now we know we have COPD. How can we check if this patient has a really damaged lung? Do we need to do it at all? No, it's not important. But it can be done if the symptoms are so severe. We will then do a CT scan, okay? It's more expensive, and we will only do it in patients who really need it, okay? And here we can detect what damage this COPD have caused. Two most important vaccinations that we will use to prevent exacerbations is influenza vaccine and pneumococcal vaccine, because these are two viruses that can cause exacerbation. As we said, 80% of exacerbations are caused by lung infection. So influenza, typical every year. So we should also take this vaccine every year. Please remember that. If you take the vaccine, you will not get influenza. Very unlikely. You can get it, of course, but it's very unlikely. So please take it yearly. It's a picture showing that it's yearly. Which medication should be given if the cause of the exacerbation is influenza? If we know that it's influenza, we have checked it with PCR or point-of-care device. Oseltamivir, peramivir, zanamivir, the mivir medications, okay? That is given for influenza patients. Pneumococcal looks a little bit different. That's a vaccination that is usually given not for children, not for younger people, rather for older people, okay? So influenza vaccination, I take it every year. I don't have any influenza. For older people, they need to take influenza vaccination, but they will also take pneumococcal one. I don't need to really take that, okay? Under age 65, which means 60, 50, 55, and so on, you can take this pneumococcal polysaccharide, also called pneumovax, or above age 65, you can take this conjugate type, or Prevnar. So under age 65, polysaccharide type. Above 65, the conjugate type, Prevnar, conjugate type. Okay. Which patients need antibiotics in COPD exacerbation? Which patients? Those who need an invasive or non-invasive ventilation. This sounds complicated. It's just a tube that is entered into your mouth and down into your lungs. That's invasive ventilation. Non-invasive ventilation is when you have a mask instead and you get the ventilation. When the patient is so severe condition that he needs this, then please always give antibiotics. There's no question. The patient needs to be staying in the hospital and get antibiotics. Or if the patient is having more than one out of these three symptoms, dyspnea, so difficulty breathing, sputum, purulence means that it's a lot of bacteria there, it's greenish, it's yellowish, or sputum volume is increased, that means that the volume is so much. So if you have all the three, of course, antibiotics. If you have only one of these, so-so. You don't need antibiotics maybe. If you have two of these, then you need antibiotics. Okay? So let's say the patient comes in, he has no difficulty breathing, but he has, let's say, a lot of yellowish, greenish, a lot of volume of sputum, then he needs antibiotic. Or if you have difficulty breathing and a lot of greenish, then he needs it also. Okay? So invasive or non-invasive ventilation, a tube entering, or a mask that's non-invasive. More than three symptoms, we said difficulty breathing, purulent is this greenish sputum that comes out of his mouth, and the volume is increased. Okay, into which two groups can we group then COPD exacerbation patients into? Outpatients, hospital patients. Why is this important? Do I treat the patient at home, or do I keep him in the hospital and treat him here? That's the question we need to ask. How do we decide that? We will see that. So outpatient is treated at home, and mostly the patients are treated at home actually. So outpatients are called is the same as treating the patient at home. Okay, and very, very, very many people are treated at home because there's no need to have a hospital in many cases. Okay, but there are cases when you're not allowed to send the patient home, and this is important for a doctor to recognize. When can you not send the patient home? And that is when the patient needs this invasive ventilation, or this mask, non-invasive ventilation, or the office treatment, meaning the patient was at my office and I tried to treat him at the spot, so half an hour or an hour, it didn't work, he is still very bad, I keep him in the hospital. Or he have a lot of other diseases that need treatment, or the patient needs help at home because he's not really, how can you say, socially, the social circumstances at home are so bad that we need to bring him in the hospital and keep him there because he can not take care of himself. So invasive ventilation, this is the tube into the lungs. Indications of this. So now we know that, okay, the patient who needs invasive ventilation needs to be staying in the hospital. But how do I know if the patient needs an invasive ventilation? That is the answer here. Severe confusion, the patient is severe confused, he's gasping breath. Facial surgery was previously done, I don't know, 1 week or 2 weeks ago. He had a trauma recently, so he's really hurt, he hurt himself, and or any deformity, he's born with a deformity, a mouth deformity or so on. We will look at all this one by one. Let's look at severe confusion. Just a picture of severe confused patient, keep him in the hospital because he needs invasive ventilation. We're talking about severe confusion, okay? Maybe this picture is not so good. This is not severe confusion. Even worse than this. It's completely severe confusion. You cannot even talk to him normally. Agonal gasping breathing. You have different breathing patterns here, You breathe normally like this. But in gasping, you see, it's like, it's completely irregular. There's no way to say that this is normal breathing, okay? Gasping breathing. Facial surgery, we said, trauma or deformity. Recent esophageal anastomosis. This is a disease, okay? You had a esophagus organ, and this is a constriction of that. High aspiration risk. The patient can aspirate into the lungs. So, for example, the content of the stomach or anything can aspirate into the lung. Then you need to invasively give this tube and ventilate him. Severe hemodynamic instability. This sounds complicated, but this just means low blood pressure. Okay, the cardiovascular system is collapsed. Shock. Low blood pressure. Okay, you put him into shock position here. Let's look at non-invasive ventilation. This is a picture of that. And indications of non-invasive ventilation are that the other one which we talked about was for invasive ventilation. But how do I know if it's indicated to doing a non-invasive? Non-invasive is not so severe as invasive. Invasive is severe, non-invasive is less severe. Here it's not severe confusion, it's only confusion. So only confusion. Use of accessory muscles of respiration, we said, the sternocleidomastoid muscles are used. Asynchrony between chest and abdominal movement, we talked about this. Normal movement is usually at the same time. The chest and the abdomen goes at the same time, but asynchrony, no sync between these, is an indication of non-invasive ventilation. Severe dyspnea, he cannot get any air. He really not gasp, because that was indication for invasive. But here it's severe, okay? You don't get any normal breathing pattern, but it's not so severe as gasping. Oxygen is less than 88%, despite that I give now oxygen into this patient's nose. He still have it less than 88%, which I check with a pulse oximeter on his finger. You see? Remember this. You get oxygen and it's still less than 88%. pH, how do I check the pH? With arterial blood gas analysis. Take a blood sample from the patient and then we see the pH is less than 7.35, then it's an indication of non-invasive ventilation because this is acidosis, it's acidic. Carbon dioxide is more than 45 millimeter mercury, hypercapnic, so too much carbon dioxide. You need a non-invasive ventilation. When do we need to switch from non-invasive ventilation to invasive ventilation? So we have a non-invasive patient. When is it so severe that we need to switch it? Because if we give this non-invasive ventilation and it's still 88%, and the pH is still less than 7.25 now, it's really acidic, we really need to take an invasive and put the tube into it because this is severe, it will die soon. Okay, so remember this. Still, regardless of having a mask, he still have 88% or less oxygen saturation in his blood, and the pH is so low, it's acidic level. Now, that was the two most difficult ones. Okay, the really easy one is office treatment don't work. See it don't work, put him into the hospital. That's it. If it works, please go home. It's so simple. How do we know if the initial office treatment is not enough? How do I know that? Respiratory rate is more than 30 per minute. So you count how many breaths does the patient take in 1 minute. More than 30, he needs to stay in the hospital. Or the heart rate. You check an ECG or you check in a blood pressure or you count the pulses, is more than 100 beats per minute. Okay? More than 30 breaths per minute or heart rate is more than 100 per minute, and that is called tachycardia. Then you need to have the patient in the hospital. Other diseases need treatment. We have a lot of other diseases. Let's check them all one by one. So we ask the patient, what diseases do you have? Or you look at the patient. For example, peripheral edema, typical, swelling of the lower legs. Renal failure, you have pain in his flank, or you know that he have a renal failure. You see it in the laboratory. You check the GFR, and you see that the GFR is very low. Renal failure. Heart failure, we know that the patient has heart failure, or you make ultrasound of the heart and you see that it's a heart failure. Confusion, the patient is confused. As we saw in the other one, that was also indication, but this is only confused. You will get this patient, you will keep this patient in the hospital. If he's severe confused, as we said, he will get invasive ventilation. Okay. Pneumonia, you have a lung infection. You keep the patient in the hospital. Arrhythmias, the rhythm is not normal as it should. Uncontrolled diabetes. So the patient is having diabetes, he takes his regular medications, and it's not controlled. The sugar levels are too high. Keep the patient in the hospital because we need to regulate the medications for diabetes also. Cyanosis, bluish fingers, bluish toes, and so on. Or the patient, social indication, need help at home. Then you keep him in the hospital. Now, outpatients. These are patients who are those that we send home. We have two groups of them. Either they are uncomplicated, very easy, or they are complicated. Uncomplicated, I have a sign here on the right side that is showing it's very uncomplicated. Complicated, I have a sign, is very, very complicated. House stands for it's outpatient. And the patient is treated at home. Two groups, remember this. The definition of complicated, this sign that we had here, the definition, remember this, is these things that we will mention now, more than 65 years. The patient is more than 65 years, then it's a complicated patient that we treat at home, so outpatient. He have heart disease. His forced expiratory volume in 1 second is less than 50%. He has more than 2 exacerbations of these per year. More than 2 exacerbations per year, and the antibiotic use in the last 3 months was used. So he took it for something, for a lung infection or something. These are complicated patients, and this will be important for the treatment. So antibiotic use in the last 3 months. Why is it important to ask if it was treated with antibiotics in the 3 months? Because if we took a medication and did not work, well, of course we need to change it, and that is the reason. And within 3 months, we need to change the medication. If we are above 3 months, let's say 4, 5 months, 6 months, then you can give the same medication because it worked. Okay? Otherwise, change the medication. Uncomplicated patients, uncomplicated outpatients, which do not have these things that I listed now, we give azithromycin, doxycycline, or 3-methoprim-sulfamethoxazole, or cephalosporins of the second or third type. Remember this, uncomplicated patients that are treated at home will be given these medications. Complicated outpatients, we need to group them into two further groups, because we have those with risk factor for Pseudomonas infection and those who are not having that. Why? Because these will get different treatment. Those with risk factor for Pseudomonas, here I have a sign of a Pseudomonas in the left corner there, and an exclamation mark showing that we have a risk factor for that. And it's a complicated sign, so it's a complicated patient at home. What do we give these patients? We will look at that soon. Before that, before giving any medication, for those who have risk factors for Pseudomonas, we need to take sputum and gram stain and culture. And then we know which type of bacteria or virus we're talking about. So please take that first. And now we go on to look at the microbiological result. And we see that he have no risk factors. No, he have risk for Pseudomonas, but he have no results. No evidence of having Pseudomonas. What do you do in this case? Levofloxacin. Levofloxacin medication in this case. So exclamation mark showing that they have risk for Pseudomonas, but have no microbiological evidence from the test we did. Okay. Now, in order to understand which patient we're talking about, we need to know which are the risk factors. So the risk factors are, for example, in the hospital, we previously isolated a Pseudomonas from sputum, then it's a risk factor, or he had bronchiectasis, or frequent antibiotics, frequent hospital, systemic glucocorticoids, or severe COPD. We mentioned all this. So previous isolation of Pseudomonas, bronchiectasis, enlarged bronchi, frequent antibiotics, frequent hospital, systemic glucocorticoids, and severe COPD. We mentioned this, but I need to repeat it, because now we're talking about outpatients who are complicated, and we divided complicated patients into those with risk factors for Pseudomonas or no. And these were the risk factors. Which antibiotics do we now give for these patients? So complicated patient who's treated at home, so outpatient, with risk factor for Pseudomonas are getting ciprofloxacin. Bam. That's it. Remember this. Complicated in the home with risk factor for Pseudomonas gets ciprofloxacin. Now, those with no risk factor for Pseudomonas will be given, then I have a sign here that is showing no exclamation mark, is showing a green sign, showing that no risk factors. These will be given amoxicillin clavulanate or levofloxacin or moxifloxacin, okay, without risk factors. So remember these pictures. And please check this video many times and you will remember it, or write it down on a piece of paper. Into which two groups can we now group COPD exacerbations into? We said outpatients and hospital. We have dealt with outpatient, we're done with that, finally. Let's look at the hospital patients. Hospital patients are here, are also grouped into two groups, and it's simple. It's exactly the same as with those with complicated outpatients, meaning we divide them into those with risk factor for Pseudomonas and no risk factor for Pseudomonas. And risk factor for Pseudomonas, I will give antibiotics for this, but I will give completely the others. So in complicated patients with a risk factor for Pseudomonas, I give completely other medication. Here you see levofloxacin intravenously, not orally, because at home usually you give tablets. In the hospital you give infusions intravenously. So levofloxacin 750 milligram intravenously, cefepime intravenously, these are all cephalosporins, ceftazidime cephalosporin intravenously, piperacillin tazobactam intravenously. These are for those who are in the hospital who have risk factors for Pseudomonas. Okay, these are the pictures showing so you can remember it. No risk factor for Pseudomonas will get something else, levofloxacin, but not 750 milligram, instead a little bit lower doses, 500 milligram intravenously. Moxifloxacin can also be given ceftriaxone, another type of cephalosporin, or cefotaxime, another type of cephalosporin. Please write this down, memorize it if you're a student. Which antibiotics can cause QT prolongation? So now we talked about levofloxacin, and these are fluoroquinolones. they are in the group of fluoroquinolones, and they can cause a QT prolongation. Where azithromycin is a macrolide. So these are medications, macrolides and fluoroquinolones can cause QT prolongation. QT stands for when you have an ECG and the Q wave and the T wave is prolonged, and that's very dangerous because the patient can die. And if you give a patient who have risk factors for QT prolongation, which are existing QT prolongation, you took an ECG, so always take an ECG before you give macrolide or fluoroquinolones. If you see that he have a QT prolongation, you don't give a macrolide or fluoroquinolone. If you have hypokalemia, so here existing QT prolongation, please don't give macrolide or fluoroquinolone. Hypokalemia, lower amount of potassium, if it's very low, don't give any macrolide fluoroquinolone. This will enlarge the QT prolongation. Hypomagnesemia, so low level of magnesium. Bradycardia, so a very low pulse, that can also cause a QT prolongation. That's a risk factor for it. Uncompensated heart failure, so the patient have heart failure, but it's uncompensated, meaning it's a worse type of heart failure. Then no macrolide fluoroquinolones, because that can prolong a QT prolongation. Amiodarone medication, the patient is taking amiodarone, that together with macrolide and fluoroquinolone can cause further QT prolongation. Or older patients, watch out with older. I'm not saying that you are not allowed to give macrolide or fluoroquinolones to older patients, but I'm saying that the risk is higher for acute prolongation with older ones. So watch out, older patients. Which antibiotic can we use now for patients with risk for QT prolongation? Doxycycline. So if you cannot use macrolide or fluoroquinolones, please use a doxycycline instead. How long do we treat COPD exacerbations with antibiotics? 3 to 7 days. So minimum 3 days of antibiotics should be given in exacerbation. In the hospital, 3 to 7 days. Okay. We are done. So to make a very quick summary, hold on, and please follow me. I have explained everything in very detail, but now I will rush through the presentation very quickly, okay? Examination. The patient comes in with wheezing. He comes in with increased breathing, more than 20 per minute. He has difficulty speaking, use of accessory muscles, and asynchrony between the chest and the abdominal motion. The test that we will do is pulse oximetry, that looks like this, arterial blood gas analysis, and we are indicated to do arterial blood gas analysis when it's an acute exacerbation, when the oxygen is less than 92%, in the pulse oximetry, when we have been given this oxygen for more than 30 minutes, we need to prevent any hypercapnia, and when the consciousness is very, very low. What can we see in the arterial blood gas? Hypercapnia, a lot of carbon dioxide in the lungs, and hypoxemia, very low amount of oxygen. The blood sample that we will do now, thirdly, we will check BNP, D-dimer, electrolyte, glucose, and complete blood count. We cannot diagnose COPD with this lab, but we will exclude all other causes of difficulty breathing. The only test that can be important is alpha-1 antitrypsin deficiency, which can diagnose or not diagnose, but it can hint that we have COPD. Now, the test that we will do, we said BNP, is to exclude any heart failure. D-dimer is to exclude any pulmonary embolism. Electrolytes, we exclude any hypernatremia or hyperkalemia. Okay, the complete blood count will to rule out anemia. So we'll look at the blood and we'll rule out that the anemia is not causing difficulty breathing. We will do a chest X-ray, and therefore we can exclude pneumonia, pneumothorax, pulmonary edema, and pleural effusion. Pneumonia is a lung infection, which we exclude. Pneumothorax is a collapsed lung that we exclude. Pulmonary edema, any water in the lungs, and pleural effusion, any water between the lung and the chest wall, which we can puncture and drain. The sputum gram stain culture can be done to look at bacteria and viruses, and the most common cause of exacerbation is lung infection, so therefore these tests are important, because lung infection are caused around 80%. No, see, exacerbation is caused 80% by lung infections. So remember that, very important fact here. The remaining 20% are environmental pollution, pulmonary embolism, eosinophilic inflammation, and unknown etiology. So environmental pollution, pulmonary embolism, eosinophilic inflammation, and unknown etiology. The ratio of viruses and bacteria are 50-50, 50%. And the most common virus-causing lung infections are rhinoviruses, but we also have influenza, parainfluenza, coronavirus, and other adenoviruses. So these are just pictures of influenza, of parainfluenza, of coronavirus, and adenoviruses. The most common bacteria are Haemophilus influenza, Moraxella catarrhalis, Streptococcus pneumonia, Pseudomonas aeruginosa, and Enterobacteriaceae. So Haemophilus influenza, Moraxella catarrhalis, Streptococcus pneumonia, Pseudomonas aeruginosa, and Enterobacteriaceae. The co-infection means that we are causing infection by both bacteria and viruses at the same time. The sign of this bacterial infection can be a purulent sputum. We perform this sputum gram stain now for every patient. No, that's not true. So we perform it only in specific patients. And it's tested in those who have risk factor for Pseudomonas, who have taken antibiotics which does not help, or who have acute respiratory failure. Risk factor for Pseudomonas are previous isolation of the Pseudomonas from the sputum, bronchiectasis or a whitening of the lungs, frequent antibiotic use, frequent hospital, systemic glucocorticoids, or severe COPD. Antibiotics which does not help needs, of course, we need to take a sputum gram stain and then attack that specific bacteria. Acute respiratory failure is clear; the patient will die otherwise. The tests that we use to detect bacteria are sputum and gram stain. As we said, for detecting viruses, it's not that. We use PCR or point-of-care device. These are completely different and more expensive devices, but they're very good for viruses. The disadvantage of using a point-of-care compared to PCR is that it's not so sensitive. So please use PCR when you want to make sure that this is which viruses it is. The viruses that we can detect are influenza, adenovirus, parainfluenza, respiratory syncytial virus, human metapneumovirus, coronavirus, and rhinoviruses. And we have some very nice pictures here. And influenza virus should be tested in all patients. Please take that into consideration. Adenoviruses can be seen here, and all this. I will not mention them once again. These are just pictures. We are making a quick review now. And diagnostic tool, we can check with high-resolution CT if the damage is very severe. And the most important things to do for patients are to get vaccinations to prevent this COPD exacerbation. We make an influenza test, influenza vaccination every year. And this medications that can be given when we have influenza are oseltamivir, peramivir, and zanamivir. Pneumococcal vaccinations are also important. We divide under 65 or above 65, polysaccharide for under, and conjugate above, okay? The patients who need antibiotics are those who need invasive or non-invasive ventilation, or who have more than one out of these three symptoms, which are difficult breathing, increased sputum purulence, and increased sputum volume. So these are the pictures of invasive and non-invasive ventilation, and the three pictures showing these three symptoms. The two groups that we can group now the patients into are outpatients and hospital patients. Outpatients are treated at home. This means that we are not allowed to send patients home only like that. Just like that, we need to rule out that the patient have any need invasive ventilation, need non-invasive ventilation, or office treatment did not work, or other diseases need treatment, or a patient needs help at home. So invasive ventilation, and the indications of ventilation are severe confusion, agonal gasping breathing, facial surgery, trauma or deformity, recent esophageal anastomosis, high aspiration risk, severe hemodynamic instability, so low blood pressure and shock. Non-invasive ventilation indications are, we have confusion, we have accessory muscle soil use, asynchrony between chest and abdominal movement, severe dyspnea, oxygen is less than 88% despite having supplemental oxygen, pH is less than 7.35, so it's very acidic, or the carbon dioxide is more than 45 millimeter mercury. We switch from non-invasive to invasive when the oxygen is less than 88%, or the pH is still less than 7.25, regardless of using the non-invasive. Office treatment did not work, we'd send the patient into the hospital. How do we know if the office treatment does not work? He breathed more than 30 breaths per minute, or the heart rate is more than 100 beats per minute. Other diseases that we need to exclude now, if the patient have this and he needs to stay in the hospital, peripheral edema, we said renal failure, heart failure, confusion, pneumonia, arrhythmias, uncontrolled diabetes, and cyanosis. Patient needs help at home. This is a social indication. The two groups that we look at the treatment, two groups. We have outpatients that we can group them into uncomplicated or complicated, uncomplicated. And the complicated definition is that he's more than 65 years of age, he have heart disease, he have a forced expiratory volume of less than 1 second, he have more than 2 exacerbations per year, he have antibiotic use in the last 3 months. So it's important to ask whether he took this antibiotic in the past 3 months, because then we need to choose another class of medication. And the uncomplicated patients will be given azithromycin, doxycycline, 3-methoprene, sulfamethoxazole, and cephalosporins orally. And then we have complicated patients which need to be further divided into risk factor for Pseudomonas or not. The risk factors, before we're giving this medication, antibiotics, we will now take sputum gram stain to just actually target the antibiotic against the specific ones. And the patients with risk for Pseudomonas but no microbiologic evidence for it will get the levofloxacin. Those with risk factors for it will get another medication, but before that we need to repeat risk factors again, because this is very hard to remember. So previous isolation of Pseudomonas, bronchiectasis, frequent antibiotics, frequent hospital, systemic glucocorticoids, or severe COPD. The antibiotics that we give complicated outpatient with risk factor for Pseudomonas is ciprofloxacin. The no risk factor group will get amoxicillin, clavulanate, or levofloxacin or moxifloxacin. The hospital patients now, we have grouped them also into two groups, those who have risk factor for Pseudomonas or no risk factors. Those with risk factor will get levofloxacin, cefepime, ceftazidime, piperazoline, tazobactam, or those with no risk factor will get levofloxacin also, but the lower doses, 500 milligram, moxifloxacin, ceftriaxone, or cefotaxime. Antibiotics should be not given, like macrolides and fluoroquinolones, when a QT prolongation is a risk. And the risk factor for that is existing QT prolongation, hypokalemia, hypomagnesemia, bradycardia, uncompensated heart failure, amiodarone, or older patients. The antibiotics that can be given is doxycycline in this case, and we treat this patient for 3 to 7 days in the hospital. And that was it. And I thank you very much. And this was a very, very rush. I know it's very, very quick. Therefore, I made it a little bit slower in the beginning and very quick in the end. And if you want to repeat this video, you can repeat it as many times as you want. If you only want to repeat the quick review part because you already remember stuff, then just go to that part directly. I thank you very much, and hopefully you understand a little bit the treatment of exacerbations, which I would say is the most complicated part of COPD. And if you know this, then you know everything, okay? Thank you very much.